Good morning, my name is Chen, and I'm a pediatric pulmonologist or a lung specialist here at UCLA. As we are well into the winter season, colds are very common at this time, and I'd like to talk about a specific type of cold called bronchiolitis and prepare you for it in the case that your child experiences one of these episodes during the season. So today my talk is, "'Tis the season for bronchiolitis." You can ask questions on Twitter using hashtag UCLAMDChat or comment on the Facebook page anytime during this talk, and I will address them at the end of the talk. Today I will talk about the definition of bronchiolitis, the causes, symptoms, and diagnosis of bronchiolitis, and the treatment and prevention of bronchiolitis, and I will close off with reasons your child should see a pulmonologist. So first, to start off, what is bronchiolitis? Bronchiolitis is the major cause of acute respiratory distress in children less than 2 years old. It is the #1 cause of hospitalizations in infants and young children in this age group, and nationwide, about 150,000 hospitalizations each year are due to bronchiolitis. However, the larger amount are seen in the outpatient clinic visits, with an average of about 750,000 pediatric clinic visits each year for bronchiolitis. Bronchiolitis is a lower respiratory tract infection, and it primarily affects the small airways called bronchioles. Now, to better understand what bronchioles are and where they are located, let's review the normal airway anatomy. Our normal airways start with the nose and the mouth, and the two airway passages meet at the back of the throat at the pharynx. And that further goes down to the larynx, which houses our voice box, down the trachea, which is our main windpipe that you can feel right here at your neck, and then that divides into the right lung and the left lung in our chest. The airway is also divided into upper and lower airways, with the upper airways making up the nose and the mouth, the pharynx and the larynx, and then the lower airways making up the trachea, the main windpipe, and the right and the left side of the lung. Now, to better understand our lungs, imagine an upside-down tree in your chest. The trunk of the tree represents the trachea, the main windpipe, and that branches into the right side of the tree and the left side of the tree. And it further branches into smaller and smaller branches, ending up with leaves. And just like the tree, our airways also divide further and further into smaller airways, which are called bronchioles, and the leaves are represented as the airway sacs. What causes bronchiolitis? So bronchiolitis is an infection of the respiratory tract, specifically bronchioles, by a virus. And the specific virus depends on the season. In this chart, I show the different types of viruses that can cause bronchiolitis and the typical seasons in which they occur. Respiratory syncytial virus here is the #1 most common cause of bronchiolitis in children. And you can usually see them in the fall to early spring. And RSV is so common that by the age of 1, half of all children worldwide will have had an infection with RSV. And by the age of 2, all children have had an infection with RSV sometime in their life. Not all of them, though, result in hospitalization. The second most common cause of bronchiolitis is called rhinovirus, and that can occur year-round. Influenza virus, also known as the flu, can also cause bronchiolitis, and we see that more commonly in the fall to winter. Parainfluenza virus is normally seen from the fall to early summer. Human metapneumovirus is normally seen late winter to early spring, and adenovirus is usually late fall to early spring. And as you can see, typically the season for bronchiolitis is between fall to winter, but you can also see it year-round. What do the bronchioles look like in bronchiolitis? Imagine our airways as a hollow tube. On the picture here on the left shows normal airways. You see that the tissue surrounding the airway, this hollow tube, is healthy and pink. And your airway opening here is widely open and clear, and that allows a good amount of air to move in and out as we breathe in and out. The picture here on the right side shows a bronchiole with bronchiolitis. And what happens is the virus causes inflammation or redness here of the tissue surrounding your airway, as well as swelling. It also causes increased mucus production. And all these three factors cause the opening of your airway to be smaller and can cause obstruction or blockage of the air moving in and out. And this is what contributes to the symptoms of bronchiolitis. And the obstruction by all these three factors can eventually cause collapse of your airways. The symptoms of bronchiolitis first start out with upper airway symptoms. And this includes runny nose and or nasal congestion, low-grade fever. Typically the fevers for bronchiolitis are less than 101 degrees Fahrenheit, cough, rapid or fast breathing, and labored breathing, which you can see as nasal flaring and chest retractions, which I will show in a later slide. Then in a few days, it progresses to lower airway symptoms, which include wheezing and crackles that your physician can hear on lung exam using a stethoscope. And you can have low oxygen levels. Typically, low is defined as less than 90%, and that's measured with a pulse oximeter in the clinic. The duration of bronchiolitis, how long does it last for? That typically depends on the age of the patient, the severity of the illness, any associated underlying conditions such as premature birth, and also depends on the virus that has caused the bronchiolitis. Typically, symptoms start in the beginning, first 1 to 2 days with upper airway symptoms, such as the low-grade fever, coughing, runny nose, and nasal congestion. Then in the next 2 to 3 days, that is followed by lower airway symptoms that is appreciated with wheezing and crackles on lung exam. Then the symptoms are worse or at its peak at day 3 to 5. And then you start to see some recovery, still with a little bit of lingering cough between days 8 to 15. Full recovery occurs with children within at least 28 days. And the groups that I mentioned earlier that may have a prolonged episode or duration of illness include high-risk groups such as premature birth, kids that are born less than 36 weeks gestational age, low birth weight. They've been diagnosed with bronchiolitis at less than 12 weeks of age. They have chronic lung disease of prematurity, particularly bronchopulmonary dysplasia. They have anatomic defects of the airways, congenital heart disease, immunodeficiency, and neurologic diseases. The evaluation and diagnosis of bronchiolitis depends on a good history, symptoms, and physical exam. There are no specific tests for bronchiolitis, so lab tests such as blood tests or x-rays are usually not necessary. But it can be considered if your child has other pre-existing conditions or they have high-risk conditions. The physical exam in a child with bronchiolitis can include cough, rapid or fast breathing, and chest retractions, which I mentioned earlier. And in this picture, it shows you chest retractions in this infant. And that's represented by the predominance of the ribs. And you can also see in this picture, you can see the lower border of the ribs. And there's also nasal flaring. And nasal flaring, as you see here, this is normal nostrils and flared nostrils. And in nasal flaring, the nostrils are wider and more open. And then they can have wheezing and crackles that you hear on lung exam and possible low oxygen levels. The treatment for bronchiolitis, so the mainstay treatment of bronchiolitis is supportive care, making sure that your child is adequately hydrated, making sure that they're able to take fluids by mouth. Nasal suctioning for symptomatic relief, because the virus that causes bronchiolitis also causes increased mucus production, and supplemental oxygen if needed, if your child has low oxygen levels that are checked at the clinic. And you want to avoid any over-the-counter cough syrups. Because bronchiolitis is caused by a virus, viruses are spread by droplets of particles that come out of our nose and mouth when we cough and when we sneeze. And so prevention is very important. The number one prevention for bronchiolitis is to practice good hand hygiene. And that includes washing hands with soap and using an alcohol-based rub if there's no soap available. Also, covering your coughs. You want to cover your coughs with your sleeve rather than your hand. And eliminating exposure to cigarette smoke. The smoke is harmful to the lungs. The cigarette smoke is harmful to the lungs. And studies have shown that children who grow up with parents who smoke or are near smoke exposure have a higher rate of respiratory illnesses and hospitalizations. And you want to avoid contacts with individuals with colds. Now, repeat infection with bronchiolitis is possible. What I mean here is, if your child has bronchiolitis, that does not completely protect him or her from another episode of bronchiolitis within the same season or even the next season. Because it is a virus, you and I and your children can be infected with the same or a different virus over and over again, which is why prevention is key. And influenza virus can also cause bronchiolitis. So the annual influenza or flu vaccine is recommended for children 6 months of age or older. And the flu vaccine has actually shown to have a 74% reduction in admissions to the pediatric intensive care unit. Now, a word about Synagis and bronchiolitis. Synagis, also known as palivizumab, is a vaccine, a specific vaccine against RSV. I have vaccine in quotations here because unlike the flu vaccine, which you get every year, or the tetanus vaccine, which you get boosters every 10 years, Synagis is required every month. It is an injection that is received on a monthly basis between the months of November to April, which are the most common months that we see RSV. And it is only for a specific population of children, specifically premature infants that are born before 29 weeks, and also premature infants born before 32 weeks who required supplemental oxygen for at least 28 days and continue to require supplemental oxygen, chronic steroids, or chronic diuretic therapy. And also infants with specific heart diseases can qualify for Synagis. So who should see a pulmonologist? If your child has had lengthy or frequently occurring symptoms, such as more than 2 episodes of bronchiolitis, more than 3 episodes of wheezing, and a cough lasting more than 4 weeks, they should see a pulmonologist. Bronchiolitis, as I had mentioned in a previous slide, lasts about 28 days, which is 4 weeks. So any cough that is more than 4 weeks can be due to another cause, which we can help to assess for. Also, if your child has had frequent respiratory infections, they should also see a pulmonologist. If your child has been diagnosed with bronchiolitis and they're over the age of 2 years, they should see a pulmonologist. Because as I had mentioned earlier, bronchiolitis typically affects children that are under the age of 2. So if your child is greater than or older than 2 years of age and has bronchiolitis, the symptoms could be due to something else. Now, if your child has noisy breathing, they should come and see a pulmonologist as well. Or if they've had a history of premature birth, history or current use of supplemental oxygen. And if your child was diagnosed with bronchiolitis but started on inhaled medications such as albuterol or inhaled steroids, they should see a pulmonologist to evaluate for other causes such as asthma, as well as the use of oral steroids such as prednisone, prednisolone, or Decadron. They should see a pulmonologist for evaluation of other causes of their respiratory symptoms other than bronchiolitis. In summary, bronchiolitis is the leading cause of acute respiratory illness and hospitalizations in infants and young children under the age of 2 years old. Now, there are far more visits to the outpatient clinics for bronchiolitis, but you can imagine the impact it has on medical care. Bronchiolitis is a viral infection of the bronchioles, which is the small airways that we saw pictures of earlier, and it causes inflammation, swelling, and increased mucus production. Bronchiolitis is a self-limited illness, and what I mean here is that your child who has bronchiolitis will get better over time, and the symptoms will resolve within 28 days. Bronchiolitis is a clinical diagnosis. It is diagnosed by symptoms and physical exam. And bronchiolitis is treated with supportive care, making sure that your child is well hydrated and able to take plenty of fluids by mouth. Synagis is for a specific pediatric population. And as we mentioned earlier, the reasons for pulmonary referral include frequent respiratory illnesses, frequent episodes of wheezing, and if your child has been started on inhaled therapies, they should come and see a pulmonologist for evaluation of other respiratory causes for their symptoms. And here we have 6 pulmonologists here in our pediatric pulmonology group at UCLA. We have clinics every day of the week, Monday, Tuesday, and Fridays in Westwood at 200 Medical Plaza, and Wednesday and Thursday mornings at our Santa Monica clinic. So if you have any questions and you want to come and see one of us, feel free to give us a call. And thank you very much for your time and for listening to this webinar. Now I will open it to questions. Okay, so the first question is, my child was diagnosed with bronchiolitis and started on inhaled medications. Is he more likely to develop asthma now? Is there a relationship between bronchiolitis and asthma? Now, that's a very good question. The relationship between bronchiolitis and asthma is unclear at this time. We know that a respiratory illness due to a virus is the leading cause of wheezing in early childhood, and studies have shown that infants who were diagnosed with bronchiolitis with severe enough symptoms that require hospitalizations are at an increased risk of having recurrent wheezing or childhood asthma. Now, the mechanism or the reasoning behind this is unclear. We're not sure whether bronchiolitis is what leads to the development of asthma or whether it simply identifies people that are, or children that are at risk or have a allergic or asthma predisposition. And the next question is, will Synagis completely protect my child from getting bronchiolitis? So Synagis is available for a specific pediatric population, kids who have high-risk conditions. And because the injection of Synagis is required on a monthly basis, the efficacy wears off unless you continue to get these monthly doses. And there is a possibility of getting an infection with RSV even if your child has received Synagis. But the idea is that the symptoms of bronchiolitis would not be as severe. And studies have also shown that Synagis has been very effective in preventing RSV-related hospitalization by more than 40% in the high-risk population. The next question is, would you recommend using humidifiers in the child's room? So there hasn't been many studies looking at the use of humidifiers, but it can be useful, especially in the winter or in the seasons where the air is drier, because the dry air can cause more irritation to your airways. So it does not hurt to try a humidifier in your child's room. If my child has been diagnosed with asthma, is she more prone to bronchiolitis? So remember, bronchiolitis is most common in children that are less than 2 years of age. In a child who has asthma, they are, depending on the control of asthma, if your child's asthma is well controlled, and when your child gets sick, and you immediately take the steps to treat the illness, using albuterol, for the cough, they are not more prone to getting bronchiolitis. But if your child's asthma is not well controlled, then your child may be more prone to bronchiolitis or just any viral illnesses or colds in general. Okay, that's it for questions. Thank you very much for your time in participating in this webinar.